Medicos. Good day to all of you. This is Dr. BK for you, and today I am going to deal with the external genitalia, mainly about the male external genitalia and the male gonads, that is the testis. And at the end I will be just briefly describing the parts of the female external genitalia also. Now first, let us try to understand the parts of the male reproductive system. So here you are able to see the sagittal section of the male pelvis. So mainly you are able to see the testis, which is present inside the scrotum, that is the male gonads. Then the sperm, which is actually produced in the testis, is transported into the epididymis and then continuing as the vas deferens. The vas deferens along with the seminal vesicle will form a single duct called as the ejaculatory duct, which opens into the male urethra. This is the male urethra, which is very long. It is made up of the prostatic part of urethra, which is inside the prostate gland. Then this small part is the membranous part of urethra, and this is the spongy or the penile part of urethra. So the parts, as I told you, the male gonads are the testis. Then what you have is the epididymis, vas deferens and the ejaculatory duct. They form the male reproductive tract or the duct system. So they are mainly responsible for transportation of the spermatozoa. Then seminal vesicle, prostate, and then you have this bulbourethral glands. They are accessory glands. So they mainly aid in transportation, add to the volume of the seminal fluid. Their secretions help again to transport the spermatozoa once it is deposited into the female reproductive tract. Okay. The urethra, mainly you see the urethra is a common passage for urinary as well as the genital system in case of the males. And external genitalia is the scrotum or the scrotal bag and the penis. Okay. So gonads are the testis, epididymis and vas deferens ejaculatory duct forms the tract or the duct system. Accessory glands are the prostate, seminal vesicle and bulbourethral glands. Urethra is a common passage both for the sperm as well as the urine. So now coming to the external genitalia, scrotum. Now scrotum is actually a cutaneous bag, okay, and it also has some muscular component. You have the scrotal sacs, you call it as right and the left side, and in between you see a raphe, fibrous raphe, which also extends on to the ventral surface of the penis. It lodges your testis, epididymis and the commencement of the vas deferens, the beginning, proximal part of the vas deferens. Then afterwards vas deferens enters into this thick cord, which is actually called as the spermatic cord. Okay. So it is, as I told you, it is divided into two by the fibrous raphe, which is also continuous with the ventral surface of the penis. Here you are able to see only the dorsal surface. The dorsal and ventral surface, the terms are actually maintained because it is more suitable for the quadrupeds, four-legged animals. Okay. So now if you look, the left scrotum is slightly lower than the right one. This is because the spermatic cord on the left side is longer. Okay. due to the length of the spermatic cord on the left side, which is slightly longer than the right side. Now, each scrotal bag has its own set of coverings. The skin actually is continuous on either side, but there is no very well built septum or something like that to completely divide the two scrotal sacs. Coming to the layers of the scrotum, first it is lined by skin. So it is a hairy skin, mainly it is a pigmented thin skin, and the skin shows number of folds or rugae or corrugated. You can tell whatever it is, rugated or corrugated, thrown into number of folds. That is because immediately deep to the skin you have the attachment of the dartos muscle. So the dartos muscle is subcutaneous, it is attached to the skin and it gives the rugated appearance. Coarse hairs on the skin of the scrotum appears after puberty. Now, the dartos muscle, when it contracts naturally, what happens is helpful for the regulation of the temperature. So thereby the skin is contracted and excess heat is dissipated through the scrotal skin, because the scrotum has to maintain a temperature lower than the body temperature for the spermatogenesis to occur. So it is almost 4 degrees below the body temperature. The scrotal temperature is actually different. Okay. So the rugousness is mainly formed by the dartos muscle, which is derived from the superficial fascia of the abdomen. If you trace this dartos muscle, it will be continuous with the fascia collis of the perineum, fascia scarpa above with the abdomen. Okay. So you are able to see that last slide I told you, median raphe of the penis, which is again continuous with the median raphe of the scrotum. This is the ventral surface of the penis you are able to see here. So mainly regulation of temperature is the main function of this dartos muscle, devoid of fat. Now why devoid of fat? Because again, if there is fat, it acts as an insulating material, so excessive heat cannot escape, it will be trapped. Then the scrotal temperature cannot be maintained and that will interfere with the spermatogenesis. Deep to the dartos muscle, you see the lining of the testis is by the external spermatic fascia, which is actually from the superficial inguinal ring. The extension of the external oblique aponeurosis continues as the external spermatic fascia. Then deep to the external spermatic fascia, you are able to see this is the cremasteric muscle and fascia. The cremasteric muscle and fascia. The cremasteric muscle itself is derived from the internal oblique and transverse abdominis. The lower detached part of the transverse abdominis and the internal oblique, they are actually present around the spermatic cord and also lines the wall of the scrotum. They are formed of series U-shaped loops, and sometimes the ascending loop fibers may also get inserted into the pubis. Okay. This muscle and the fascia, what happens is it helps to pull the testis upwards. The cremasteric muscle is actually supplied by genital branch of genitofemoral nerve. It is a voluntary muscle, but still it shows reflex actions. Cremasteric reflex, when you stroke the medial side of the thigh, naturally the testis is pulled upwards. It's a protective mechanism which we will discuss later in the inguinal canal. So skin dartos muscle, external spermatic fascia, then we have the cremasteric muscle and the fascia. So the testis and the epididymis, these are the coverings of the scrotum from skin, dartos muscle, external spermatic fascia, cremasteric muscle and fascia. Then you have the internal spermatic fascia. The internal spermatic fascia is actually from the fascia transversalis. Okay. The fascia transversalis forms the internal spermatic fascia. Then deep to that you have the parietal layer of tunica vaginalis. The tunica vaginalis is actually developed from the processus vaginalis, which is the fold of peritoneum. That processus vaginalis, when it comes, it forms a double layered fold. One layer is adherent to the scrotum as the parietal layer. The other layer will be applied over the testis as the visceral layer of tunica vaginalis. So between the two layers, it is a closed sac. Both the layers are continuous with each other. Between the two layers of the vaginalis, they are continuous and they don't communicate with the rest of the abdominal wall. If they communicate, then they produce a condition called as the hydrocele. So what is the main function? So before that, I will again enumerate the layers of the scrotum, starting from skin, dartos muscle, external spermatic fascia, cremasteric muscle and fascia, internal spermatic fascia, and parietal layer of tunica vaginalis. So functions mainly, to some extent, it protects the testis from the external injury. Then regulation of temperature helps to maintain the temperature, which is 4 degrees lower than our body temperature. This is responsible for the spermatogenesis to occur. Otherwise, spermatogenesis might not occur, or the formed spermatozoa might actually die. Okay. So maintenance of ambient temperature for the spermatogenesis, that is the other function of the scrotum. Edema, collection of fluid inside the scrotum, is common. So the scrotum might become swollen. The most common reasons are, one is hernia, herniated loops through the inguinal canal. Intestinal loops might herniate via the inguinal canal or directly via the superficial inguinal ring and might present as a swelling. Hydrocele is collection of fluid because most commonly congenital is patent processus vaginalis, and other condition is filariasis, when there is obstruction of lymph vessels. Then also you actually come across the scrotal edema, filariasis, okay, or called as elephantiasis. So we have seen about the scrotum, the layers of the scrotum, the function of the scrotum. Now we will move on to the male gonads, that is the testis. So males possess a pair of testes, which is again present inside within the scrotal sac. The left testis is slightly lower than the right testis. That is the reason again, because the left spermatic cord has a greater length. Suspended in the scrotum by the spermatic cord. Okay. So the parts of the testis, it consists of an upper pole, lower pole. It has got a medial surface, lateral surface, and it has got an anterior border and a posterior border. 2 poles, 2 surfaces, 2 borders. 2 poles, upper and lower pole, 2 surfaces, medial and the lateral surface, 2 borders, anterior border and the posterior border. The upper pole of the testis is related to the head of the epididymis, and sometimes you also come across a small fibrofatty tissue which is the appendix of testis. The appendix of testis is nothing but the remnant of the Mullerian duct. Okay. So the appendix of testis is a remnant of Mullerian duct. Mullerian duct is nothing but the paramesonephric duct, which is responsible for the formation of the female genital tract. So upper pole related to the head of the epididymis. Lower end is again related to the tail of the epididymis. Okay. So the epididymis actually invests the upper pole, then posterolaterally, and then the lower pole is related to the tail. Epididymis invests the upper pole, posterior border, and the lower pole of the testis. Anterior border is actually smooth and convex. Posterior border, as I told you, laterally related to the epididymis. Medially you can see the vas deferens. From the tail of epididymis is again turning backwards and ascending upwards is the vas deferens. Posterior border, laterally related to the body of the epididymis. Posterior border medially is related to the upper part or the proximal part of the vas deferens. Medial surface is actually smooth and convex. Medial surface is not seen in this view. Lateral surface, you are able to see the lateral surface. There is a space between the epididymis and the testis, and that space is actually called as the sinus of epididymis. Okay. So that is the sinus of epididymis, which is related to the lateral surface of the testis. So the sinus of epididymis is an important feature by which you can actually decide the side of the testis. Very helpful in side determination. Hold the testis in such a way that the sinus is facing laterally, then naturally it belongs to that side testis. If it is facing laterally and left side, then it is left testis. If it is facing laterally and to the right side, the sinus epididymis, it is the right testis. Now we come to the coverings of the testis. The outermost covering, mainly it is made up of three coats. We call it as tunica albuginea. Before that we have one more layer, that is the visceral layer of the tunica vaginalis. Tunica vaginalis, tunica albuginea, tunica vasculosa. So these are the three layers or the coverings of the testis. Tunica vaginalis, if you trace above, again it will be continuous with the parietal layer of the tunica vaginalis. Visceral layer and parietal layer are continuous, so it is a closed sac. Tunica albuginea is a thick fibrous coat. Something it can be considered as the capsule for the testis. Albuginea means thick white. Okay, tunica is a coat. If you trace this thick tunica albuginea along the posterior border of the testis, it projects into the testis, forming a septum called as the mediastinum testis. It is not a complete septum dividing the testis into two equal halves. Just posteriorly, to some extent, it forms a septum called as the mediastinum testis. So the tunica albuginea projects to form a mediastinum testis. From the mediastinum testis is the inward invagination of the tunica albuginea behind. From there you can see fibrous septa arise and divide the testis into various lobules. Okay. From the mediastinum testis, fibrous septa arise and divide the testis into numerous lobules. So each testis has got around 200 to 300 lobules. So outermost covering, you are able to see this blue colored one is the two layers of the tunica vaginalis. That is the parietal layer and this is the visceral layer. I told you both are continuous above and below, so it is a closed sac. Deep to that, this thick layer, what you are seeing is the tunica albuginea, which actually projects inside the testis as the mediastinum testis, and then fibrous septa you are able to see here. Then the innermost, that apart from the tunica albuginea, you are able to see these blood capillaries. They line each lobule of the testis, and that forms the tunica vasculosa. But they don't enter into the lumen of the testis. Okay. So mediastinum forms fibrous septa dividing the testis into 200 to 300 lobules. If you take a section of each lobule, the base is near towards the surface and apex is actually near to the mediastinum. This septum here is the mediastinum. So roughly triangular or conical in shape. Inside each lobule you have 1, 2, 3 seminiferous tubules. So these highly coiled structures, you are able to see these highly coiled structures here, they are these seminiferous tubules. So each lobule has got 1 to 3 seminiferous tubules. So that means roughly each testis will have, if it is 200 lobules into 3, 600 seminiferous tubules. So each tubule is lined by the tunica vasculosa, which I already told you. But the vessels do not enter the lumen of the tubule. There is a barrier which is present between the wall of the seminiferous tubule and the blood vessel, which is called as the blood testis barrier. If the blood enters into the seminiferous tubules, then it will produce antibodies against the developing spermatozoa and it will kill all the antibodies. And that in some persons it happens and it is called as anti-sperm antibodies, one of the causes for male infertility. Okay, anti-sperm antibodies. So that is why there is a blood testis barrier. So tunica albuginea, then followed by tunica vasculosa. Now these seminiferous tubules, these highly coiled structures, as they reach the mediastinum testis, they become straightened out. Okay. Now before that, you are able to see the seminiferous tubules. A cut section of the seminiferous tubules consists of varying stages of spermatogenesis. Spermatogonia, which gives rise to primary spermatocytes. They are actually from the type B, spermatogonia, giving rise to primary spermatocytes by mitosis. Then they will give rise to secondary spermatocytes by first meiotic division. The secondary spermatocyte will give rise to spermatids by second meiotic division. Second meiotic division. Now, if you take the total length of the seminiferous tubules, you can see the spermatogenesis at various stages, almost 6 stages you can see, and it almost takes around 64 days for the spermatogenesis to actually complete. Okay. In between the spermatogonia, you see some pale triangular cells. They are actually called as the Sertoli cells or sustentacular cells. They provide nutrition to the developing spermatozoa. They also form tight junctions in between, support. In between or confluence of the seminiferous tubules, these areas are called as the testicular interstitium. Interstitial cells of Leydig are actually present there. They only secrete the testosterone. Usually in fetus, interstitial cells are present, then slowly they disappear and again appear after puberty. It is under the influence of ICSH, interstitial cell stimulating hormone. So interstitial cells of Leydig, they actually synthesize the testosterone. Apart from that, you have blood vessels, lymphatics, nerves, all in the testicular interstitium. Okay, so which contains the Leydig cells. That is the inside the lumen of the seminiferous tubules. Now, if you look the seminiferous tubules, they get straightened out as they reach the mediastinal testis, and they called as the tubuli recti. They are called as the tubuli recti, which means they become straight from coiled. And these tubuli recti, they form a network of tubules. They form a plexus or network which is actually called as the rete testis. This is actually called as the rete testis. These rete testis, they pierce the tunica albuginea as the efferent ductules. So 15 to 20 efferent ductules from the rete testis, they pierce and then enters the head of the epididymis. So the head of the epididymis is mainly formed by the fusion of these efferent ductules into one single duct, which is very highly coiled. You are able to see the epididymis is nothing but a single epididymal duct which is highly coiled. So the spermatozoa which are actually produced here are transported, and then maturation takes place in the epididymis. So epididymis mainly consists of caput, corpus and cauda epididymis. Caput is head of the epididymis, corpus is the body of the epididymis, and cauda is the tail of the epididymis. Sometimes you also see again a small nodular tissue which is called as the appendix of epididymis, which is seen here. This is the remnant of mesonephric tubules. Mesonephric tubules, not the duct, the mesonephric tubules. So the efferent ductules, they all fuse and unite to form the head of the epididymis, convoluted, highly coiled, and they inside have the canal of epididymis. They form the canal of the epididymis, union of the efferent ductules. So as I told you, superior and inferior remnant ductules, aberrant ductules are appendix of epididymis. Then from there what happens is the epididymis, the head of the epididymis, cauda, sorry, not the cauda, it is actually the caput epididymis, continues as the corpus and then the cauda epididymis, which is related to the posterior border and also to the lateral part of the posterior border of the testis. The spermatids, through the suction action, enters here, and slowly what happens is they undergo maturation process. They get capacitated. Capacitation is not to be confused with the capacitation which takes place in the female genital tract. Here the capacitation is, it becomes competent enough to actually penetrate the barriers of the ovum. The testis is mainly supplied by the testicular artery, a branch, direct branch from the abdominal aorta, enters through the spermatic cord. Then you have artery to vas deferens, branch from superior or inferior vesicular artery, which is again a branch from the internal iliac artery. Then cremasteric artery, it's a branch from the inferior epigastric arteries. So testicular artery, artery to vas deferens, and then the cremasteric artery. You are able to see these branches of the testicular artery, they break into numerous small branches, and then they line the seminiferous tubules, each lobule, thereby forming the tunica vasculosa. Centripetal arteries, and they form interlobular branches, and that is the epididymis and the vas deferens. You are able to see here. So mainly it is from the testicular artery, then you have the artery to the ductus deferens and the cremasteric artery. Veins, so 15 to 20 veins, they emerge from the posterior border, and then what happens is they become 8 veins, 4 veins, Before these veins form pampaniform plexus and gradually reduce in number. That's what I told you. They become 8, 4, 2, and ultimately they emerge as single testicular vein from the deep inguinal ring and drain into the inferior vena cava on the right side, whereas the left onto the left renal vein onto the left side. So the right testicular vein drains into the inferior vena cava, whereas the left testicular vein drains into the left renal vein. So they usually start as a pampaniform plexus of veins, then they unite to form 4, 2, and ultimately a single vein. The nerve supply sympathetics is from T10 to T11 segments of the spinal cord. So that is why I already told you the same segmental innervation, the skin of the umbilicus is innervated by the T10 or T11. So you feel referred pain from the testis around the umbilicus. Now coming to the descent of the testis. So originally it is developed in the posterior abdominal wall. You see the gonadal ridges on the posterior abdominal wall, which is mesodermal in origin. Intermediate mesoderm gives rise to your genitourinary system. Now inside this ridge, the primordial germ cells, they will migrate from the wall of the yolk sac and then come and settle here. So originally, which is present in the lumbar region, posterior abdominal wall, it gradually descends from lumbar region to scrotum during the various stages of the fetus. So it reaches the iliac fossa in the 3rd month, then deep inguinal ring in the 7th month, superficial inguinal ring in the 9th month and 8th month, and ultimately in the 9th month what happens is upper part of the scrotum. So that is how it descends. Just before birth, in the 9th month, it enters into the scrotal sac. That is called as the descent of testis. Now I will just play a short video so as to understand how the testis descends. I won't be able to speak when the video is playing because that video itself has a music. Okay. So this is the testis and the epididymis, you are able to see here. See how kidney originally it was here above, slowly it has descended. It brings a fold of peritoneum. So that is how the testis is descended. Once again I will repeat this. See, it passes through the muscles of the anterior abdominal wall, that is through the inguinal canal, and ultimately it will reach the scrotum during the 9th month. Now, what are the main factors which are responsible for the descent of the testis? There are so many factors which are enumerated. I will also enumerate these factors. Increased intra-abdominal pressure. So slowly the coils of intestine, they are growing, increasing in length. So more and more as the intestinal grow, there is lack of space and all the abdominal organs are enlarging. So this pressure might act as a driving force for the testis to move downwards. Hormonal factors, mainly androgens. Not only that, the fetal testis itself secretes an hormone. Interstitial cells, they start secreting, and that is one of the driving force for the testis to actually commence its descent. Then differential growth, we call it as uncurling fetal curves. So fetus slowly starts uncurving, and differential growth of the anterior and posterior abdominal wall. Anterior abdominal wall and posterior abdominal wall might grow at a different growth rate. So because of that, again what happens is the testis will descend. Then the most important factor is the gubernaculum testis. So it is a fibromuscular band from the lower pole of the testis. From there what happens? Through the inguinal ligament will go and split into many processes called as the Lockwood, tail of Lockwood. It will insert into the pubic bone, scrotum, upper part of the thigh, and all these split process, when they contract or when they retract, it will pull the testis downwards. Okay, gubernaculum testis. The gubernaculum testis is absent in elephants, so that is why the testis is intra-abdominal in case of the elephants. So extends from the lower pole, which is the gubernaculum testis, fibromuscular band, and splits into various bands, gets attached to the perineum, pubic bone, inguinal region, even to the umbilicus and upper part of the thigh. When these bands shorten, what happens is it has to come down. So bring the testis down due to the pull exerted by this. Any abnormal pull results in ectopic testis. That means it might go somewhere apart from the scrotum, medial side of the thigh. Okay, that is most commonly, or sometimes it might undescend and present intra-abdominal itself. Okay. So this is again a short animation, very fast, and you are able to see. I will repeat 3 or 4 times. So as the testis descends, you are able to see this fold of peritoneum here. Processus vaginalis. This brown color line is the processus vaginalis. This green color one is the gubernaculum testis, which is getting shortened and pulling downwards. Then these pink, blue are all muscles of the anterior abdominal wall. While it is descending, it is bringing a coverings of the testis along with it. So this pink, external oblique aponeurosis, external spermatic fascia. Green color is internal oblique, which will give rise to cremasteric muscle and fascia. Then this red color one will be the fascia transversalis, which will form internal spermatic fascia. Then that brown color one is the fold of peritoneum, that is your fold of peritoneum, that is your processus vaginalis, which forms the tunica vaginalis. 2 layers, parietal and the visceral layer. Okay, so when the processus vaginalis, what happens is this part should cut off and only this should be present. If there is a continuity, then it is called as patent processus vaginalis, and it will lead to congenital hydrocele. Otherwise, the distal portion is present, proximal portion should obliterate. See, on the right side, testis has not descended. It is called as monorchidism. One side it is not descended. Simply undescended testis is cryptorchidism. When one side it is not descended, it is called as monorchidism. So we have seen about the testis and the epididymis. Next we will pass on to the vas deferens. So what is vas deferens? It is a part of male duct system, reproductive tract, present within the spermatic cord along with the other structures. 45 centimeters in length and continues from the chorda epididymis and related to the posterior border, medial part of the posterior border of the testis, posteromedial aspect of the testis. Then, as I told you, it enters into the spermatic cord, forming one of the constituent or the main constituent of the spermatic cord. Then traverses the inguinal canal, passes through the inguinal canal. Then on the lateral wall of the pelvis, very intimately related to the external iliac vessels. Then turn downwards, medially downwards, related to the posterior part of the bladder. Joins near to its termination, it forms an elevation, an expansion which is called as the ampulla of vas deferens. joins with the seminal vesicle forming the ejaculatory duct which opens. This is the ejaculatory duct through which it opens into the urethra inside the prostate, the prostatic part of urethra. Okay, the terminal part is actually called as the ampulla. Opens into the prostatic part. See, this is the prostate gland. It is traversed by the urethra. Opens into the prostatic part of urethra via the ejaculatory ducts. So transportation and storage of sperm. So mainly not only transportation, storage, it is also responsible for maturation of the sperm. That is what latest concept they tell. So even it is stored there throughout the length of the vas deferens. You have these sperms stored. So vasectomy, so very common practice, male family planning in case of males. So here what happens is just at the upper end, when it leaves the testis, the two ends are severed and tied. Spermatogenesis stops immediately after this operative procedure, but after that it resumes. So there is no need to fear as the male might become impotent. Okay, so that is called as vasectomy. The next procedure is vasovasotomy. Is again recanalization of the spermatic cord. So again it can be, the cut ends can be sutured back, which is called as vasovasotomy. So it can, the vasectomy can be reversed with the vasovasotomy procedure. So spermatic cord, thick cord-like structure. So from the deep inguinal ring to the superficial inguinal ring, extends from the deep inguinal ring to the superficial inguinal ring up till the posterior border, upper part of the posterior border of the testis. So the coverings almost same like the coverings of the scrotum. From inside, if you start internal spermatic fascia, which is from the fascia transversalis, prolongation of it, it brings this yellow color. The next, from the transverse abdominis and the internal oblique, cremastric muscle, this detached part of this muscle forms the cremastric muscle and fascia. Then from external oblique aponeurosis, prolongation from the superficial inguinal ring, this white color is the external spermatic fascia. Internal spermatic fascia, cremastric muscle with loops of muscle fibers, and external spermatic fascia. Contents of the duct, spermatic cord, mainly the vas deferens, which is called as the ductus deferens. So mainly you have the ductus deferens, then you have the artery to the ductus deferens, along with cremastric artery and testicular artery, surrounded by pampiniform plexus of veins. Nerve is genital branch of genitofemoral nerve, which supplies the cremastric muscle. Then you have lymphatics and sometimes remains of the processus vaginalis, which is the peritoneal fold which has descended urine. So actually the processus vaginalis should obliterate upper part, and the lower part remains as tunica vaginalis, which is a closed sac. The upper part is present, and if it is not obliterated or patent, it might create hydrocele condition, or it might also lead to herniation. Okay. So contents is ductus deferens, artery to ductus deferens, testicular artery, cremastric artery, pampiniform plexus of veins, genital branch of genitofemoral nerve, lymphatics, and remains of processus vaginalis. So coming to the clinical anatomies, hydrocele, as I told you, accumulation of fluid in the scrotum. Two types, might be congenital or acquired. Congenital, I told you, it is because of the patent processus vaginalis just now I described. When the processus vaginalis does not obliterate the upper part, continuation with the peritoneal cavity is not severed, then you can see it is patent or communicating, which leads to fluid collection. Sometimes it is severed, but middle part alone is present, that is called as encysted hydrocele. Like a cyst, it is present. Upper part and lower part, there is no continuity. It is obliterated only in the middle part. Okay. Acquired might be due to any injury or trauma to the testis. Any infections might be gonorrheal or sexually transmitted infections. Because of that, what happens is you also get collection hydrocele, filariasis. Next is varicocele. You have seen about varicose veins of the lower limb. Here, varicose veins of the pampiniform plexus is actually called as the varicocele. So, if these veins are actually inflamed, then there is no proper venous drainage. It is actually like a plexus surrounding the spermatic cord. So that what happens is the heat exchange from the arteries to the veins is taking place. So when the venous drainage is sluggish, then naturally what happens is, because of that, again it might interfere with the spermatogenesis. Sluggish venous drainage might increase the temperature of the scrotum, and thereby it might interfere with the spermatogenesis. So again a cause of male infertility, varicocele. So it has to be surgically, you remove the pampiniform plexus of veins. Coming to the next external genitalia, which is the penis, male copulatory organ. It is traversed throughout its length by the urethra, the spongy part of urethra, and the urethra again shows a dilatation prior to its termination, which is called as intrabulbar fossa, and then opens into the external urethral meatus as a slit. Okay, antero-posterior slit. Throughout the length it is traversed. The penis is traversed by the urethra, so you call it as penile part or the spongy part of the urethra. So it is somewhat pendulous in the flaccid state, but becomes stiff when it is erect. So parts mainly consist of root of the penis, then you have the body of the penis, and then you have the tip of the penis. Okay. The root is through which it is attached to the pelvic bone. Then the body of the penis is, part of the body is inside and then part hangs out, and then what you have is the tip where it ends. The root is mainly formed by the two crusts of the penis, and then what you have is the crust of the penis. Here you are able to see the two crusts attached to the conjoint ischiopubic rami. To the conjoint ischiopubic rami is actually called as the crux of the penis or crura of the penis. These deep crura, they what happen? They unite to form a single part which is called as the corpora cavernosa. Corpora cavernosa. Root has got two crura and other one which is expanded called as the bulb of the penis. It is actually called as the bulb. So three masses are two corpora cavernosa, and this is called as the corpus spongiosum. Corpora spongiosum. Why it is called as corpora cavernosa? If you take a section, you are able to see these two has got numerous spaces. Okay, so I'll come to it later. Corpora cavernosa, which forms the crux of the penis, and in midline the bulb of the penis. The bulb of the penis will be traversed by the urethra. Okay. So these two are actually covered by ischiocavernosus muscle, the crux, and the bulb is covered by the bulbospongiosus muscle. So two crura unite anteriorly, as I told you, anteriorly and also above or dorsally to form the corpora cavernosa, covered by the ischiocavernosus muscle. In between these two, you have between and below you have the bulb, which is formed by the corpus spongiosum. So that is your ischiocavernosus muscle and the bulbospongiosus muscle covering your crux and the bulb of the penis. So corpus spongiosum, as I told you, is pierced by the urethra. If you look at the body of the penis, so mainly it's all the three erectile mass corpora, two corpora cavernosa and corpus spongiosum, they unite and form the body or the shaft of the penis. It's also called as the shaft of the penis, free and pendulous, covered by skin. And what happens, the skin which covers this part beyond the tip is actually called as the prepuce. Foreskin that covers the glands. Now here the prepuce has been retracted to actually expose the glands. So the anterior part of the penis expands into a conical structure which is actually called as the glans penis. And at the tip of the glans penis you see the external urethral orifice as an antero-posterior slit. Frenulum is actually the median fold which you see in the ventral part. Okay, so this is actually the glans penis. This fold of skin which you see on the under surface or the ventral surface is the frenulum of the prepuce. The frenulum, what happens, has to be free or long enough, otherwise the prepuce cannot be retracted, and that condition is actually called as phimosis. Phimosis, phimosis. Sometimes the frenulum might tear, it is called as frenulum tear, and might result in hemorrhage. So elongated conical structures called as glans penis, and near to the base of that cone, that raised margin is actually called as the corona glands. It is actually called as corona glandis. And beyond that, this constriction is actually the neck of the penis. This constriction is actually called as the neck of the penis, constricted part behind the corona glandis. Okay, I have written behind the neck, sorry, that is a small mistake. The prepuce has got glands, preputial glands, and they produce a specific odor, and that secretions are actually called as spegma. They are actually called as the spegma. So we have seen about the structure of the penis, parts of the penis, root of the penis, shaft and tip. The root mainly consists of two crura and one bulb. Shaft are three mass of erectile tissue, corpora spongiosum and corpora cavernosa. Then you have the glans penis, corona glandis, neck, preputial skin. Tip of the penis is actually pierced by the external urethral orifice. So arterial supply for the penis mainly by deep artery of the penis. So the deep artery pierces this corpora cavernosa, and all these spaces will be filled by the helicane arteries. Normally in a flaccid state, what happens is the arterial ingress is less than the venous egress. Venous drainage is more than the arterial ingress. During erection, what happens? These spaces are actually filled by the blood, and these spaces gets dilated. When these spaces become enlarged, then it will impede the venous return. So the state before the venous return starts, up to that the erection is maintained. So erection is more of a vascular phenomenon rather than a nervous. Of course the stimulus should come nervous, but it is a vascular phenomenon, maintenance of erection. So once these dilated cavernous spaces slowly starts to dilatation comes down, venous return starts, then the penis will come to a flaccid state. So mainly supplied by deep artery, dorsal artery and artery to the bulb of penis. Veins, deep dorsal vein and superficial vein of the penis. Lymphatics, glands, penis, deep inguinal nodes, cloacoid nodes inside the femoral canal. The rest is by superficial inguinal nodes. So finally, coming to the female external genitalia, the parts of the female external genitalia are It is called as vulva or pudendum. Mainly consists, this opening is the vestibule of the vagina. The vestibule or vaginal opening is surrounded by labium majus. Then you have the labium minus. The labium majus unite above and form a raised area called as the mons pubis. So it present with coarse hairs and deep to skin. What you have is fat. Then the clitoris and then the greater vestibular glands you see. So the vestibule is mainly the space between the two labium minora. These two is actually the labium minora folds. These vestibule mainly consist of the vaginal orifice posteriorly and the urethral orifice anteriorly. So they are folds of skin with underlying fat, labium majora. Genital swellings. When these genital swellings fuse anteriorly in males, it forms the scrotum. Here they are unfused and they form the labium means majora. Labium means or lips. Anteriorly fuses to form the mons pubis. Minora is medial to it, again thin folds of hairless skin. Labium minora, and they unite to form the clitoris, which is actually equivalent to the male penis. It has also got erectile tissue, ischiocavernosus, but spongiosum is absent. Corpora spongiosum is not there. Okay, so that is the clitoris, union of the labium minora, which is rich in sensory receptors. This opening is the vestibule, which consists of the vaginal orifice posteriorly and the urethral orifice anteriorly. So with this we have completed the external genitalia. Thank you for your patient listening.